Okay, chapter 17, the last chapter in the book, is on basic dermatology. We're going to go through a lot of skin conditions in this chapter that you are not necessarily ever going to see or need to remember, but just listen and know that sometime in the future it may come across again. You may see it, and just remember that at some point you heard about it. So the objectives are to identify threats to skin integrity, to describe the intrinsic and extrinsic factors associated with aging skin. This is the most important objective of this particular chapter. Is just you're going to work with a lot of geriatric patients potentially, and understanding the skin, the way that the skin changes with aging is incredibly important. We're going to identify some common dermatological conditions that may be encountered in PT, and then understanding your role in the management of these conditions. So, basic dermatology, the duty of the PT or duty of the clinician is to first of all, recognize and document the presentation of a skin disorder. You want to assess it. You want to assess any skin changes. Skin changes can be as a result of something specifically related to the integumentary system, or it can be in relation to other systemic problems. An example of that is there are drug reactions that you'll see. For example, baclofen. Baclofen is pretty famous for giving a rash, and you'll most likely see patients who are on baclofen for management of spasticity. And if you see this rash, red, angry rash erupting on the skin, it would be really important for you to identify that and to let the physician know. So as it says here, you would refer to another provider if the situation you identify it, and someone else needs to know. In the case I just gave, it would be the physician, because they would want to change. They would want to look at the level of baclofen in the body, because it is causing a reaction. So that's important for the PT to identify. So primary functions of the skin, we went over this, I believe, in the first chapter, and here we're going over it again in the last chapter. Protection, sensation, metabolism, thermoregulation, and communication. So what happens with skin in aging? So due to time and then the cumulative effects, because we are outside, your skin is exposed to the elements. It's exposed to sun, as it says here. It's also exposed to variations in temperature, like severe cold can cause changes. But the two most common problems that we see with patients in nursing homes. So the two most common skin types, sorry, I had to plug in my computer there, are xerosis and pruritus. Xerosis is dry skin and pruritus is itching. So dry and itchy skin are the two most common skin problems with patients in nursing homes. Obviously, the dry skin can be related to changes in moisture in the skin, drugs in this, drugs that the large number of drugs geriatric patient may be taking, pharmaceuticals, the environment, if it's a very dry, heated, like really well heated environment in their room because they keep it hot, then they're going to dry out the skin. So there's many things that can cause also dehydration. We've talked about elderly do not drink generally at some level of dehydration because they're the fear of falling or just movement to get up and go to the bathroom. They limit the amount of fluids they take in. So all that leads to dry skin and itching. So Some of the skin changes with aging are decreased dermal ground substance, elastin, and collagen. If you remember back to the very first chapter when we talked about the skin itself and the physiology of the skin itself, this all relates to that. There's a decreased epidermal turnover and vitamin D production. There's flattened dermal papillae, and the way that the skin attaches the layers, the epidermal and the dermal layers. If you remember, the reed pegs and the dermal papillae are where the epidermis and the dermis attach, so that as they flatten, then you have a higher risk of skin tears. There's a decreased dermal and subcutaneous thickness. There's decreased vascularity and immune response, and decreased sweat glands and skin elasticity, which the decreased number of sweat glands can also relate to the dryness that we were talking about earlier. There's a decreased barrier function, decreased sensory perception and immune function, decreased moisture content, and as we've talked about. There's a thickening of the nails and decreased thermoregulation. So let's talk a little bit about dermatology terminology. So a rash are temporary eruptions of the skin, whereas a lesion is a pathological or traumatic loss of normal tissue, continuity, structure, or function. So in other words, if there's an opening or if there's a fissure, if there's some kind of splitting, that's a lesion, whereas a rash are eruptions just on the skin. They're not necessarily open. So a primary lesion are the first ones that you see, and they may progress to secondary lesions, which as we'll get to, but secondary lesions are generally more under the skin. So primary lesions are all of there's names, the names that you see here are all names for primary lesions. And then this slide shows you the difference between all of the things that we just talked about. A macule can be just a small discoloration under the skin. A wheal would be a little bit of a raising of the skin. A papule would be a bigger raising of the skin. A vesicle or boa is a fluid field. As you can see, it's kind of not it's empty. There's empty space underneath it. A nodule or tumor is larger even still, and then a pustule is something that is between the dermal and epidermal layer, and it is filled with pus. So primary lesions are non-palpable flat changes in skin color. A macule, or I'm sorry, primary lesions which are non-palpable and just flat changes in skin color are the macule and the patch, and that the naming of it depends on the size of it. So a macule is less than or equal to 1 centimeter. A patch is greater than. An example of this would be if you've ever known anyone who has psoriasis. Psoriasis, they have patches because they're usually large. So that's an example of what you would call a patch. It's a flat change in skin color. A palpable or elevated solid mass is either a papule or a plaque, a nodule, a tumor, or a wheal. And each of these, again, it's related to the size. It's related to the firmness. It's related to whether there's anything inside of it or how deep it goes. I'm not expecting you to know all of these names, but just realize that primary lesions do have different names depending on the size. Superficial elevations formed by fluid within a cavity or between tissue layers. These are the ones that are like your blisters, vesicles, bulla, pustules. Again, depending on the size, it also depends on what they're filled with, because the pustule would be filled with pus or any kind of purulent material. So secondary lesions are depressed and they're below the plane of the skin, and those are such as scales, crust, excoriations, abrasions, fissures, erosions, ulcers, and scars. Other factors to consider are seasonal skin conditions. I did talk about earlier in one of the earlier slides that changes can happen not only as a result of the sun, so there can be actually burns to the skin. We've already seen the sunburn, but there also can be changes to the skin as a result of cold, severe cold to the skin. There can also be skin conditions, and we've seen this due to lack of hygiene, lack of adequate food, overcrowding. Skin conditions are more prevalent amongst non-Caucasian people, just because if you think of the population of the earth, of the worlds, then there are more non-Caucasian people who live in crowded conditions with lack of hygiene and adequate food. Other things that you need to think about when you're looking at something that on your patient's skin that has, that doesn't look normal is what is the shape and configuration of it? What's the arrangement, the distribution, grouping, evolution of it, or involution? So, asking the patient about any kind of things that you can think of about how it started or how it's progressed. The color, the texture, the consistency. These are all things that need to be considered. So here's a little mnemonic that will just give some ideas of how to assess any dermatological eruptions. Two types of dermatological eruptions that we need to talk about are eczema and dermatitis. Their inflammatory skin response to any injurious agent. Eczema is endogenous, meaning that it's coming from inside the body. Dermatitis is exogenous, meaning it's happening because of something that's happening on the skin. It's outside the skin itself. So these patients present with dry skin. There's patches, papules, plaques, with or without scales. I talked earlier about psoriasis, but also eczema is where you can see the patches. Skin can appear edematous, and there can be excoriations due to itching or to the scratching because it itches. These are very the patient's going to really want to scratch these because the itching is so constant. So in a chronic case, they may have really thickened skin. We talked about lichenification with the lymphedema patients. You can also see it with someone who has chronic eczema or dermatitis. And you often see it on the neck or the flexor surfaces. The eyelids, the forehead, face, and the dorsum of the hands and the feet. The treatment is just to figure out what's causing it and then remove that. If your patient comes into you and says, I've suddenly got this thing going on and I'm not quite sure what it is, you would want to help them to identify anything that's new and different in their life, both internally and externally that they have come in contact with, but you would also want to refer them back to the physician. So dermatitis, the different types of dermatitis, there's allergic, there's contact, hand, seborrheic or seborrheic, and stasis. So when you are looking at these, the contact, allergic and contact, you just want to determine what is irritating them and avoid exposure to it. Hand dermatitis is a result of topical steroids. Seborrheic is hydrocortisones. And then stasis, when you're looking at a stasis dermatitis, you need to think about leg elevation, compression garments, exercise, and what kind of topical agents you can use for a stasis dermatitis. This is an example of a contact dermatitis. You can see if you look on the other side of the incision, there's some redness here There's some papules here. You'll see some raised parts of the skin. This is a reaction to a bandage. Most likely, this is a reaction to the adhesive on the bandage, and that's why you see the discoloration. This is an example of a contact dermatitis due to the adhesive from an electrode EKG. EKG electrode, sorry, backwards there. But the adhesive, people who react to have contact dermatitis often react to adhesives on electrodes or band-aids or, any kind of adhesive that is put on the skin. Urticaria is itchy, edematous, pink or red wheals or hives. It can be acute or can be chronic. It is commonly associated with any kind of food, medication, an exposure to an allergen. For example, contact with poison ivy will give you this, or a chemical. You can use if you use a cold pack, I've already talked about the adhesives that can cause it, but you can also get this with you can see this in some people with use of a cold pack. So when you're using cold therapy, you need to be really careful about this one, because some people are highly sensitive to it. So always check your patient after about 5-10 minutes of use, when you're using a cold pack the first time, to make sure that they're not getting you're not seeing urticaria. So it can develop after ice massage, electrodes, or therapeutic taping, manual therapy. Again, check a small area, check the skin response. If it gets really severe, the doctor may put them on an antihistamine so that their body doesn't react in that way. Psoriasis is a chronic recurrent inflammatory disease. They don't know what causes psoriasis, but it is inherited. It does seem to be passed down amongst family members, but it's round, erythematous, dry, scaling plaques that are covered by silvery white scales. Um, Generally, you can see it on the scalp, the nails, the extensor surfaces of the extremities, elbows, knees, umbilica, and sacral regions. You have both pustular and non-pustular types. Um, I think I've spoken to you about the patient with psoriatic arthritis that we saw, and his the majority of them were just scaly, large scaly patches, but he did have some that were pustular in nature, so that there were some eruptions. Again, we treated him on an annual basis with hydrotherapy, basically scrubbing the plaques and opening up the areas, and he healed. Um, Patients may also have psoriatic arthritis, as I just talked about. Currently, there's no cure, but you can convert the disease from active to latent stage using systemic and topical steroids and immunosuppressives, ultraviolet therapy, and coal tar products. The coal tar products sometimes are way more messy than they're worth. UV is far less messy than coal tar, and patients respond to it much better than they would coal tar. Benign neoplasms and hyperplasias. So you just need to recognize that if you see something you that wasn't on the patient before, a mole or something on the skin, a skin tag, something that wasn't there before, just alert the physician to it, or alert the patient to go to the physician to it. You don't scare them about it, but you just make sure that they get it checked out. So here's the ABCDE method to detect melanomas. Hopefully you guys have heard this. This is out in the public. There's a lot of they're trying to educate the public about this, but as physical therapists, it's really important that you know these, so that when you see something on a patient, you can recognize it and you can send that patient immediately to a physician. But the ABCDE is asymmetrical. They have uneven borders. The color, it's usually brown, tan, or black. The diameter is larger than a common mole, so it's greater than 6 millimeters, greater than or equal to. And in elevation, it can change in size, it can change in shape, it can change in color, it can be bleeding, or it can actually be crusting. Nevi are moles, and if they start to change in color or size or bleed or become very itchy, then you want to make sure that the patient is referred to a physician. Mongolian spots are congenital, typical in the lumbosacral area, and our next slide we'll see a picture of it, but it's common in Amerindian and Asian infants, but it disappears in early childhood. You'll probably never see a Mongolian spot, but here's one in a 17-month-old child. A capillary hemangioma. These, if you ever see one on a child, you'll recognize it, but it's huge, bright red or deep purple nodules or plaques, but they're benign and they usually disappear by age 5. Port wine stains also, if you've seen them on anyone, you'll recognize them, but they're irregularly shaped red macular vascular malformations that are present at birth. Generally, you see them on the neck, around the face, the forehead, the eyelids. Generally, there's no treatment, but it's just a disorder or malformation that is present at birth. A cherry angioma is asymptomatic bright red domed lesions. They're benign. Usually you'll see them on the trunk, and you'll see them in older patients. These are actually pretty common, but again, when you see them, you'll recognize them, but they're benign. Seborrheic keratosis is most common benign epithelial tumor. It is flat, well-demarcated, small brown pigmented areas. Over time, they can become raised and darker with a soft, crumbly surface. These are very common in older persons. It looks kind of like a mole, but it starts to take on this kind of well, it says a soft, crumbly surface. It takes on this I don't know, almost like a furry, if you will, almost like a furry top on it. And again, as you work with the elderly, you will probably see some of these. Skin tags are cutaneous papillomas or fibromas. They're just soft, round, and they're the color of skin. They can be tan or they can be brown, but and they're all benign. You don't have to have any kind of medical treatment. You do see these in the elderly and obese patients. You want to make sure that when you see these, you don't twist when you're doing manual therapy or any modalities on this patient. You're not twisting that skin tag because you can make it bleed. So you just have to be careful if you see a lot of skin tags that you're avoiding torsion of it when you're doing manual therapy or using any kind of modalities, or even if you're using like a weight on them, like a cuff weight on them, or if you're using TheraBand around the skin, just be very careful that there's not a torsion on the skin tag, so you can tear it and it can bleed. Lipomas are single or multiple fatty tumors. You can feel them under the skin. They're painless. You'll see them every now and then on patients, and what is that? And the patient will tell you that it's a fatty tumor or lipoma. Generally, they don't really cause any problems. Dermatofibromas are little nodules. Usually you'll see these on the extremities. And when you pinch them, the dimple sign means that there's a dimple within the lesion. So more important for us to recognize and to refer is to talk about skin cancers. Skin cancers are as a result, as we know, of exposure to ultraviolet rays, harsh weather conditions, leisure activities in the sun, decreased ozone layer. So there's more skin cancers now than there used to be. And as the ozone depletes, we'll see probably even more. And then there's a couple of different types. Basal cell carcinoma, squamous cell carcinoma, a malignant melanoma, and a Kaposi sarcoma. The last one is rarely seen unless the patient is HIV. The patient has HIV positive, because Kaposi sarcoma, most people's immune system takes care of it before it becomes a problem, which is why the patient with HIV would be the only patient that you generally see this with. So when do you become suspicious about a lesion? If there's rapid growth over weeks to months, the diameter, if it's larger than 6 millimeters, we had talked about that earlier, changes in pigmentation, inflamed margin, irregular ragged borders, crust formation, bleeding, and itching. Remember, the ABCDE will also help you to know that if a lesion is suspicious. Basal cell carcinoma is the most common form. It's small pink or flesh-colored nodules. They enlarge over time. They may depress in the center or even ulcerate. They can be hard to distinguish from normal aging skin. When they go in to take out a basal cell carcinoma, they have to go into deeper tissues. They can't just go across the top because the skin cells, the basal cells are usually extend in much deeper. They generally don't metastasize, but 80% of them are on the head, neck, and face, where we have a high rate of exposure to UV rays. Squamous cell carcinoma is a malignant tumor of the outer epidermis. There's scaly elevated lesions with irregular borders and central ulcers. They can be local or they can be invasive, which is metastatic. 40% of patients will have recurrent squamous cell carcinomas, and only 2 to 6% will metastasize. The treatment, they either surgically excise them, which again, they have to go into the deeper tissues, or they use cryotherapy. A malignant melanoma is a rapidly progressing metastatic melanocyte cancer. There's irregular borders, uneven surfaces, it's black or brown. It can be red, inflamed, and the surrounding area would be very tender, and it may bleed or ulcerate. These are something that if you see something, it's important that you refer the patient rapidly. Suspicious tumors are generally surgically excised with a wide margin, and they may go so deep that you have to have a skin graft to close it. They use immunotherapy, chemotherapy, radiation therapy if it's metastasized, but early recognition of these is absolutely imperative for there to be a cure. Here's an example of a malignant melanoma that's on the top of the head. Kaposi sarcoma is malignancy of cells lining the blood vessels. It's linked to herpes virus 8 and HIV. It begins with a macule and evolves into papules, pustules, nodules, and tumors of various colors. They can be local or widespread, and they may involve the lymph nodes, but it is not contagious even if it's open. I did see a gentleman with a Kaposi sarcoma that had multiple open areas that communicated with each other throughout his body. He was HIV positive, but his Kaposi sarcoma, they used chemotherapy on him, and it would decrease the numbers of them, and he would start to heal. And then as they ended the chemotherapy, then it would exacerbate again. Cutaneous pigmentary disorders. There's the normal skin color. It has 4 different biochromes in it. There's brown, yellow, red, and blue. So skin color is determined by a combination, but melanin is the main determinant, as we discussed in the first chapter. Albinism is a congenital disorder that affects skin, hair, and eyes. And so what happens is their body does not have the enzyme to actually synthesize the melanin. They may have melanin in their body, but their body can't break it down. So they have pale or pink or pale skin, yellow or white hair, and very light colored eyes or sometimes red eyes. They're highly susceptible to sun damage and sunburn. Vitiligo is a loss of melanocytes. There are distinct borders on the face, neck, axilla, and extremities. It's inherited, and it's found in people with thyroid disease, pernicious anemia, and diabetes. Some people have spontaneous repigmentation, so the white spots that you see will spontaneously repigment. And cosmetic interventions are available. It was said that Michael Jackson had vitiligo, and that's why you saw the spotty whiteness, or he would bleach to bleach out the rest of his skin. Melasma is light or brown hyperpigmentation. This is often caused, you see this, it's often called a pregnancy mask. You'll see it when women are pregnant on the face. It can be caused by sunlight, pregnancy, oral contraceptives, or it just happens. But a lot of times they'll call it a pregnancy mask because there's this browning of the skin on the face during pregnancy. Sun exposure can exacerbate it, and it may disappear after childbirth or cessation of contraceptives. These are, let's see, freckles and liver spots, phthalitis and lentigines are freckles and liver spots. Obviously, that's why we call them freckles and liver spots, because the other names are not well known. But freckles are sun damage, and you do have to watch freckles, because subtle changes can mean that they've turned into some kind of pathological disorder. And then liver spots are small brown lesions, frequently on the back of the hands, the neck, and the face. Again, areas that are frequently exposed to sun. People also call them, instead of liver spots, they call them age spots as well. So you'll often see them on the backs of the hands of an elderly person. Systemic disorders, so a systemic disease can involve the skin, and drugs taken for systemic conditions can cause adverse reactions involving the skin. I talked about earlier the baclofen, so there's a baclofen rash that does happen. That's an example. Another systemic disorder is a systemic lupus erythematosus, or SLE. It's a progressive disease, mainly involving the internal organs. It has to do with the connective tissue of the body. You see cutaneous involvement in 80% of cases. So there's a butterfly facial rash. You see changes in the nails. There's macular eruptions on the trunk, and there's lesions in the oral mucosa, like inside the mouth or inside the vagina of a woman. But these are symptoms of SLE. Again, with SLE or with lupus, you can also see other more severe systemic disorders because it does affect the connective tissue. So you can see a susceptibility to stroke due to arterial breaches. So there's many things that come along with lupus besides just the skin eruptions. Discoid lupus erythematosus is a chronic dermatological condition without organ involvement. It most commonly affects the neck and the face. You get these skin lesions that are round or look like a psoriasis kind of. Just need to protect from the sun with sunscreen and clothing. These can also be treated with topical corticosteroids from the physician. Scleroderma is a slow progressive inflammatory incurable disorder. It involves the skin and the internal organs, and basically what happens is the skin becomes hard and stiff, and this spreads to it's the skin, but then it also spreads to the internal organs, and when an internal organ becomes hard and stiff is when this disorder becomes deadly. But physical therapy interventions, daily range of motion, manual therapy, warming modalities to try to help keep movement, keep range, keep the skin mobile. Adverse cutaneous drug reactions. So there are symptoms that are usually mild that are accompanied by itching, and they resolve promptly when the drug is stopped. These are allergic drug reactions. They can be immunological and they're not dose dependent. So just a little bit will make you react as much as a lot. Non-allergic drug reactions generally are toxic, but they're dose related. Or they're idiosyncratic, which means they just happen without any. It just happened without any warning. So if this is suspected, you need to obtain a thorough history. What were they taking? When did they first take it? When did the symptoms begin? Common causes are sulfa-based drugs, penicillin, anticonvulsants, and NSAIDs. And reactions can be life-threatening. So the people with these kind of cutaneous drug reactions, it's not something that you should take lightly because they can lead to anaphylactic shock. The skin reaction or the cutaneous reaction can be your first warning sign. So this is something that really need to, when you see a reaction, any kind of reaction on the skin, you need to investigate it further. Here's an adverse drug reaction. There's a series of pictures we're going to see in the next couple of slides. And it follows by date. So here you see a rather small blister, but you see a lot of redness in the skin around this area. And this is on June 15th. 2 days later, you can see that the redness has gotten deep purple, and you see more blistering, and there's an open area on the leg. And another day, you see more blistering. All of that was purple looking is now turning into blisters, and the opening is getting larger. On July 4th, you see that this skin has completely sloughed off, and now there's a lot of necrotic tissue on there. And then you can also see that there's the epidermal layer that has come off in a larger area. This is an example of a ulcer due to chemotherapy drug infiltration from an IV site. If a patient has an IV site and they're getting anything through that IV that could harm the skin, if it doesn't go directly into the vein or the artery, if it happens to, the needle is not placed correctly, it can infiltrate and damage the tissue surrounding that artery. This is an example of when the tissue was damaged by the chemo that was going into the hand because the IV was not put directly into the artery but was allowed to go into the tissue surrounding the artery. There's a couple of bacterial skin infections. Impetigo and eczema are superficial infections of the epidermis. eczema can extend into the dermis. I don't know that you'll see these a lot. You generally can see these sometimes in children, or in maybe crowded places, just because it is a bacterial infection. The impetigo is the most common form, is blistering on exposed parts of the bodies that rupture, and it leaves crusted erosions that last days to weeks. Again, most common in children. And eczema is found on the lower extremity of debilitated patients, and this one lasts weeks to months. Other bacterial integumentary infections or skin infections that you may see are abscesses, furuncles, and carbuncles. It's a infection of Staph aureus. So it begins as a red nodule, and then you see it developing into purulent material. These are often called boils. So they're firm, tender nodules near hair follicles, and they can be 1 to 2 centimeters in diameter. Often we would call these infected hair follicles, but it really is a furuncle or a carbuncle. So a carbuncle is a deep extension of 2 or more coalescing furuncles. So the treatment is, a lot of times the doctor will go in and do I&D, which is incision and drainage, and then they'll use antibiotics, moist heat, topical agents such as a antimicrobial, Bactroban or Neosporin or something like that to just get rid of the bacterial infection. Cellulitis is a acute infection of the dermis and the subcutaneous tissue. It's tender, it's red. You can see the patient also may have fever. They may just not feel good, have chills. It can be severe if it spreads, if it spreads enough, and it can require hospitalization. There would need to be some superficial debridement, that you need to use topical medications on it. And the Whirlpool generally, although as I've said before, Whirlpool is probably not something that you guys are going to see a lot because it's not used a lot, but previously there was a lot of Whirlpool done, and cellulitis, you don't want to use a Whirlpool because the legs are hanging down into the tank. You don't want that dependency if the cellulitis is on the legs. Here's an example of cellulitis. You can see the patchy areas. It's red. It's multiple areas that are open. This is just classic of what dermatitis looks like. Other viral or common viral skin infections are varicella zoster, which is the herpes virus. It's chickenpox. It's chickenpox and shingles. It can be spread by airborne particles or by contact. And chickenpox are pruritic macules or papules that become vesicles. After infection, the virus lays dormant in the dorsal root ganglia, and that's how it can come back as shingles. So when it's reactivated through illness or stress, you get these papules and vesicles along the corresponding dermatome. They use antiviral agents or corticosteroids, and just time. Over time, it will resolve. Tinea pedis is athlete's foot, and I'm sure there's some of you who have seen this or maybe even had it. It's a fungal infection. It's primarily in the interdigital spaces in the plantar feet, but it can be in other locations. It's characterized by redness, itching, scaling, maceration, or you can see little bulla or little not pustules, but little raised welted areas. But it's contracted by walking barefoot or wearing a very exclusive footwear. The spores can live up to 1 year in skin scales, which is why it's so hard to get rid of, because it has to be treated for a very long period of time. The treatment is an antifungal, topical. Sometimes they have systemic drugs that they'll give to get rid of it, but the prevention is proper foot hygiene and footwear. Uh, Candidiasis, or a yeast infection. So Candida is a normal microflora that's in the mouth, the GI, and the tract, and the vagina. But what happens when someone gets on a high dose of an antibiotic, it can cause the normal flora to not be there, so that the yeast can take over. And you can see infections in skin folds and under dressings. It's red and pustular, and there can also be these white, cheesy adherent masses on the mucosa. So especially on the tongue, if you see someone who has a yeast infection on the tongue is just coated with this white, um, white mass, and it's incredibly painful. Generally, it's incredibly painful. So high risk is those with decreased immunity, diabetes, infection, chronic steroid use, those who work with frequent exposure to water, or have been on a long course of antibiotics, as I said earlier. Treatment is antifungal. Sometimes they do topical, sometimes they have to do a systemic, and then the protection is to keep it clean and to protect from extra moisture. So if there are skin folds that there is a yeast infection in, then you have to make sure that those folds stay dry, so that there's some kind of a wicking material that goes under there. It can even be as simple as a clean white handkerchief, or clean white cotton cloth that can go in the skin fold, just to keep it from becoming moist, um, and um, and irritating, or increasing the growth of the yeast. So the nail disorders that we can see are changes in the integrity, the color, the thickness, and or clubbing of the nail. And this can be due to trauma, infection, or systemic disease. These are all things we'd want to note if you see this in your patient. If you see something going on with the nails, you might want to ask. The treatment can be topical medications. For example, there's the very famous nail fungus, the little guy on the commercials. So there are topical medications you can put on there. They can surgically remove the nail if it becomes so severe that the nail can't be treated. And if there is a systemic cause to the nail disorder, then you do have to treat the underlying pathology. So one of the things that you need to consider is to be aware of potential irritants for yourself and for your patients. This is especially important with latex. You may have heard there's a lot of people that are developing latex allergies because of a prolonged exposure to it. It's really important, if you have any kind of reaction to latex, that you let someone know, because over time um, this can become crucial, in that it can develop into a more severe reaction, and can become the worst, of course, the most severe reaction being an anaphylactic reaction. So it can affect the respiratory system. So it's really important that if you notice any kind of reaction in yourself, or maybe even your patient, that you identify it and try to figure out what is causing it. Because long-term or frequent exposure can definitely develop and promote sensitivities. Common reactions are, you see a dermatitis or a contact dermatitis. Avoid the irritant and use proper hand hygiene. So when you have a patient that has a suspicious lesion or a dermatological condition, you really want to be very careful about using any kind of modalities on them, because you don't know what that modality, how it may affect that lesion or that dermatological condition. You may want to test in a very small area and see what reaction happens, what happens to the patient's skin. So the other thing is that you, of course, want to make sure that any electrodes or any equipment that you use on someone with a suspicious lesion or dermatological condition, that you sanitize it properly after use. So this talks about a little bit about normal and abnormal variations in non-Caucasian skin. So because people often will say in someone who has darker skin, I really can't tell the difference. You can tell the difference if you're looking at the skin and you're watching the skin. They're more difficult to detect, but as it says here, you want to look and feel for skin changes. So you want to look for a dusky kind of change in skin color. So you want to look for temperature discrepancies. You want to look for the firmness of the skin. All these things can help you to see when there's variations in non-Caucasian skin. Normal variations are hypopigmentation over the sternum, um, variations in the nail bed, so there can be different pigmentation and dark bands. And then you can see the oral mucosa inside the mouth can be blue or blue-gray. That's a normal variation in black skin. And then the palms and the bottom of the feet, you can see hyperpigmentation. These are all normal variations of the skin.